Yeah, it's live.
So we are live on YouTube. Jashan, I think so. We start.
Yes, sir. We can start. We are live.
Yeah. Good afternoon, members, dentists, fellow colleagues, senior dentists, practitioners. Welcome you all. Today's special welcome to Dr. Makran Jejurikar, sir, who has been a senior practitioner since approximately 40 years, 45 years. Welcome, sir. Today is the 19th webinar lecture of Indian Dental Association Mumbai West Suburban Branch. All these webinar lectures have been conducted for free from the branch. Welcome you all. On the 19th lecture today, we have Dr. Vinayak, who is going to demystify the doubts, the basics of CBCT, that is computer beam radio tomography. There are a few forthcoming webinars which are going to come. Tomorrow we have Dr. Amit Gupta's webinar on bone graft substitutes. Yeah, right. It's on the screen. Bone graft substitutes, where and what to use, by Dr. Amit Gupta, an oral and maxillofacial surgeon. After that, we have Dr. Parag Kelkar's lecture, that is on day after tomorrow. And then we have one more from our forum itself, Dr. Kapil Gulwankar, who is going to speak on post and core on 19th of this month. Friend, all these webinars are telecasted, are live, are shared on the YouTube channel of Indian Dental Association Mumbai West Suburban Branch, that is IDA MWSB. Do visit the channel, subscribe, share and like. All the previous webinar lectures will be available for your reference on this YouTube channel. There's a request to all the members who are here on this stage. Plenty of them, in fact 95% of the members are on either of the groups of Indian Dental Association MWSB webinar groups from 1 to 5. Either webinar 1, webinar 2, webinar 3, webinar 4 or webinar 5. Please request you all the programs, all the webinars of IDA MWSB are going to be broadcasted, and all the messages regarding this webcast, these webinars are going to be posted on these 5 groups. If you are a member of any of these groups, please do not rejoin any other groups. Humble request, the password, meeting ID and everything will be shared 15 minutes before the start of the webinar, and the YouTube channel link will be shared the moment YouTube channel goes live. Request you all to mute your audios and stop your videos so that the streaming becomes smooth and simple, and each and everybody can listen to the webinar without any video lag or audio lag. So enjoy today's webinar of CBCT. Dr. Jashan Arora, I would like to request you to introduce our today's speaker, Dr. Vinayak Shirsekar.
We have today with us Dr. Vinayak Umesh Shirsekar. He is the chief radiologist and founder member of Dentex 3D. He has completed his BDS from the prestigious Nair Hospital and Dental College and has done his MDS from MGV Dental College in the field of oral medicine and radiology. He is actively involved in CBCT reporting since 2013. He has an experience of thousands of CBCT scan reporting. He is a prolific speaker on CBCT, conducting lectures and hands-on courses in association with IDA, as well as in many dental colleges and conferences. He is actively involved in the research related to CBCT and has various article publications in his name. He has 4 years of teaching experience in the field of oral medicine and radiology. He has undergone advanced training in CBCT and integrated implantology in Germany in 2016. Please welcome Dr. Vinayak Shirsekar. Dr. Vinayak, the screen is all yours. Thank you. You can start with the screen share. Yeah, thank you.
Thank you, Dr. Jashan, for your kind introduction and the kind words. And good evening, everyone. Dr. Jashan has already introduced me. These are the tough times, and we have to learn from it and evolve through it, just like a field of dentistry and the radiology. So we have evolved from IOPA to OPG to digital world to CT scans to CBCT. There were disadvantages of each and everything which has been overcome, and today we have reached to CBCT. So CBCT is the latest development in the field of radiology. Now, what is CBCT, right? CBCT stands for cone beam computed tomography. That means why cone? The shape of the beam is cone shape, hence it is called as cone beam computed tomography. So what happens is, just like how an OPG works, it is the same thing, same principle. The X-ray beam and the source will rotate around the patient in a single sweep. So while rotating in one go, it will take on the entire scan, right? So the difference is the shape of the beam. It is in the shape of a cone. And the receptor. The receptor is not a normal one-dimensional receptor. It is a two-dimensional receptor. So while rotating or while revolving around the patient, that X-ray beam will take on multiple X-rays. These X-rays would be a two-dimensional X-rays, and it will take out a series of 600 to 500 X-rays. How a machine gun shoots, it shoots various shots in a go. Similarly, the X-ray source will take 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 700 X-rays, two-dimensional X-rays, while it is rotating. So each individual X-ray is called as a basis, frame, or a raw image. Then the software, it will join all those two-dimensional X-rays, and you will get a three-dimensionally reconstructed data called as a projection data. So this is your 3D data, which has been reconstructed from a series of hundreds of two-dimensional images, which are one after the other, right? And then this data is again, we can apply various algorithms and softwares to see it. So in short, the X-ray source and the receptor will rotate around the patient in a single go, right? And then you will get a three-dimensional data. This data is then, with the help of our softwares, we can see it in various planes. So this is the simple basic how a CBCT machine works, or a CBCT works. Right? Now, what are the advantages of CBCT over the normal two-dimensional imaging, or why do we go for a CBCT or a three-dimensional imaging? We'll see some examples. First of all, the two-dimensional image or a OPG image, it is distorted image. It is never 1:1. That is always magnification in an OPG. Whereas in CBCT, you get 1:1 images. So they are accurate. What is in the scan, it is the exact measurement as what is in the patient's mouth. So this is one major advantage of a CBCT scan, that the images are undistorted and they are accurate. Second thing is, in OPG, we get to see only structures which lie in a focal trough. There is something called as focal trough, and the structures which lie in this focal trough, only they are clearly seen in an OPG. Structures outside the trough, they are not clearly seen. But in CBCT, the advantages is we can draw our own focal trough. We can adjust the thickness of the trough so that we can incorporate the structures which are outside it, and we can see it in all the three planes. Like here, we are seeing from the side, from the behind, and from above. So we can see it from all the three planes, and we can adjust what we want to see. So that is another advantage. This is Harvey Dent. This is a villain from The Dark Knight. Is also known as Two-Face Harvey. He was a good cop, Gotham's DA. And but what happens with time, he turns into a villain. Circumstances turn him into a villain. But the people of Gotham, they know him only as the good hero. So this is what an OPG will show you. But the CBCT will show you is Two-Face. That is why it's called as Two-Faced Harvey. Now, what are the advantages? in two-dimensional images or an OPG, there is overlapping of the structures. Suppose if we are examining maxillary posterior region, then you have your teeth, you have your alveolar bone, you have your maxillary sinus, you have your zygoma. So all the structures, they are superimposed over each other. So if there is pathology in one of them, it is very difficult to identify in an OPG where the pathology is. But in a CBCT scan, we can separate these things in various slices and see them individually and can lead to accurate diagnosis. For example, if you see this two-dimensional radiograph, what you see is there is an impacted premolar, right? There's a premolar over here, but we don't know whether it is labially placed or whether it is palatally placed, and whether it is touching the teeth or away from it. But if you take a CBCT scan, here you can make out that it is palatally placed. Right? You can see, and it is in contact with the tooth. It is touching the tooth. So this can be seen in a CBCT scan. Another example, if you see here, there is this third molar and it is in close proximity to the inferior alveolar nerve. But we don't know whether it is touching the nerve, whether it is labial to nerve, or whether it is buccal to nerve. But once we take a CBCT scan, we can easily make out. Now, if you see this, this is that third molar, and this blue dot is the nerve. So we can see that the nerve is lingual to the third molar and it is compressed between the lingual cortex as well as the third molar. Right? So this cannot be seen on a two-dimensional radiograph. Now in this case, there is a fracture line in 2-1. Here we can see exact horizontal as well as vertical extent of this fracture line. If you see here in 2-6, there is periapical radiolucency, maybe because of short obturation. But when we take a CBCT scan, here we can see this mesiobuccal root has two canals. Can you see this? This is MB1 and this is MB2. So the MB1 is not filled. Also, it is short of the apex. That is why there is this periapical radiolucency. So we have seen the advantages of CBCT over two-dimensional radiograph. Now, what is the disadvantage? The major disadvantage is the dose. Now, if you see this DPT, it is digital panoramic tomography, which is an OPG. So for a digital OPG, the dose is 0.015 millisievert. So for the CBCT, it is 0.068. So roughly, it is 4 times for a single OPG. So it is as good as taking 4 to 5 OPGs, the dose of a CBCT scan. So that is one major disadvantage while comparing to a two-dimensional image. But if you compare it with a CT scan, here, the CT scan is 0.6 millisievert, whereas in CBCT is 0.06. So the dose in CBCT is 99% less than that of the CT scan. So anytime when we want to see for hard tissue structures like the teeth and the bone, a CBCT scan would be helpful. Now, after seeing the advantages of CBCT over two-dimensional imaging, we will go to interpreting the scan. But before interpreting the scan, we should know where we will look, what we have to look, and how we have to look. So to read the scan, there are many sections, there are many views, there are many formats which we should know. So I will show you some sections and what are the things. So there are sections, there are reformatted views, and there are 3D views. The first section is the axial section. The axial section is through the axial vertebra. So it is like you are looking from up or looking from down. So this is your axial section through the axial vertebra. Now it is good for visualizing root canals. This black dots in between, they are the root canals. So this is the axial section. Next is our coronal section. It is through the coronal suture, right? So it divides the body into front and back. So it is like you are seeing from front or seeing from behind. So this is what is your coronal suture. And your third is your sagittal plane or sagittal section. It is through the sagittal suture. So it is like we're seeing from the left or seeing from the right. So these are the main 3 sections. Now for implant planning, unfortunately our arch, it is horseshoe shape. So it neither lies in the coronal section nor does it lies in the sagittal section. So it is better to use the word cross sections, which is the buccolingual section of the tooth, right? So this buccolingual section at the incisor area, this is the buccolingual section at the molar area. So these are nothing but cross sections. Why we should avoid coronal and sagittal? Because see, this cross section is sagittal in the anterior region, but similar cross section, if you want, it is coronal section in the posterior region. So to avoid the confusion in the terms, it is better we use a single term for planning or measuring the implant width and height. That is cross sections, which is buccolingual section of the tooth at any given point. So this is the incisor region, buccal and palatal, maxillary molar, buccal, palatal, lower incisor and lower molar, buccal and lingual. So this is the cross section. So these are the sections. Then you have reconstructed views. Now in CBCT, we can draw our own curve. We can draw dots and make our own panoramic curve. And we can adjust its thickness also. So that is called as a reconstructed panoramic curve. So importance of this view is it acts as a base view while scrolling. If you want to scroll through a scan volume, so this reconstructed panoramic view will appear and it will act as as your reference point to check where your scans are or where in which region you are. This is for the mandibular arch. Next is your multiplanar reformation view. Multiplanar reformation view is good to localize any object, any impacted object or any foreign body or anything you want to localize, then this view is important. Why it is called multiplanar reformation? Because here you can see all the three planes, axial, sagittal and coronal, as well as a 3D view. So this is multiplanar reformation view, which is important or which is useful if you want to locate a impacted object or locate any object. Next comes the implant view. Now, whichever company CBCT machine you will be using, the software, it will have all these basic view. It will have a panoramic view, it will have an MPR view, and it will have an implant view. So basically the rough implant view would be a axial image. There would be a reconstructed panoramic image. And like I said, it acts as a referral or basis. So there are what are the lines on this? 1, 2, 3, 4, 5 vertical lines. And as you see here above, there are cross sections at these lines. So cross sections are the buccolingual sections, right? Buccal and lingual, it is written. So this is buccolingual section at this point. This is buccolingual section at this point. Third one is here. So these are the cross sections. So we can scroll through these sections in the software. We can do the measurements and etc. So these are the 5 lines and these are the corresponding 5 cross sections. These can be moved and the scan can be studied. Now all the softwares will have these tools. There will be a scale in all the softwares with the help of which we can do the measurements. You can measure the height and width. There would be an angle like this, something to measure the angulations, and there would be something to measure the bone density. Now bone density in CBCT, it is never accurate. The CBCT will never give you bone density in Hounsfield units. It will always give you subjective density. What use Hounsfield units in CBCT, they are third-party softwares. They assess the scans and they will give you a subjective value. It is not the accurate Hounsfield unit as you get in CT scan. So the what the values you get of bone density in CBCT, they are always relative. They are never accurate. And after this, there is the 3D reconstruction view. This 3D reconstruction view is very important to study the shape of the bone, the anatomy of the bone, whether there is any curvatures, whether there are any undercuts, whether there are any fossas. All these things can be nicely studied on the 3D views. But we should never study the bone level on the 3D view. I'll tell you why. Because when these 3D views are constructed, it is constructed on the basis of some threshold value. Now, if you see our bone also, all the bone is not uniform, it's not of uniform density everywhere. Somewhere it is soft, somewhere it is hard, right? Even the structure, the soft tissues, they will have less density. bone will have higher density, enamel will have higher density, right? So everyone has that one threshold or one assigned value for it, right? So when it is constructed, it is reconstructed at a single value. So the structures which are below that threshold, they are not seen on your 3D reconstruction. So sometimes bone would be there, but it would be less dense and it won't be seen in your 3D view. Like if you see these two views, these are the views of the same patient, but I have just adjusted the threshold. In this, suppose the threshold is 6. So the structures with threshold 6 and above are seen. Now I have increased the threshold to 10. So the structures with threshold 7, 8 and 9, they are not seen, right? So you never go on the bone amount of bone present on the 3D view. You can see it on the slices. There you will clearly see the bone present, but you get to see the anatomy. So this is how we can see the scan. So there are 3 types of views. One is a sections, axial, coronal, sagittal. Then there are reconstructed views, OPG, that is panoramic view. Then you have multiplanary formation, implant view, and you have your 3D views, right? Now there are some terminologies which I would like to tell you. There is something called as field of view. Field of view is nothing but your area of exposure. The area your scan needs to cover is the field of view. So it can be large, it can be medium, it can be small, depending upon your need. If you want to study for a single tooth, then you can go for a small field of view. If you want to study a single arch, then you can go for a medium field of view. If you want to see both arches, then you go for something which is a large field of view. The advantage with the small field of view is the voxel size can be reduced and you can get more sharper images, but they are little darker. Now there is something called as stitched FOV. Stitched FOV is if a CBCT machine has a small FOV like 5 by 5. 5 by 5 means 5 centimeter by 5 centimeter volume it can cover. So if it has a 5 by 5 FOV, then it can only cover 5 by 5 area. And if you want to scan an entire mandible in such patients, in such machines, then you'll have to take 3 scans, 1, 2, and 3. Then these 3 scans, they are joined by the software. This is called as stitching or stitched FOV. Right? So now we will go to image interpretation. For image interpretation, we must know how does a normal image looks like and how does a normal anatomy looks like. Because only when we know the normal, we can judge what is abnormal, right? So this is how a normal tooth or things look like. Like how in an IOPA it looks, your soft tissue and your air spaces would be radiolucent, right? So wherever there is air present, your oral cavity, your nasal cavity, your maxillary sinus, it would appear as pitch dark, this thing. So this is completely black. So this is your air cavity, right? Now your soft tissue, the mucosa, the cheek, buccal mucosa, the tongue, the palate, buccal and labial gingiva, they will all appear as gray areas. So if you see these gray areas, this is nothing but the soft tissue. So this might be the soft tissue of the tongue. This is the buccal mucosa, this, right? And your teeth and other structures, they will appear as they appear in an IUPA. So this is enamel, which is the most radio opaque. Then you got your dentine, and then you got your pulp. Right? So the pulp will appear as radiolucent area. So on axial sections, now if you could see this radiolucent dots, these are nothing but the pulp running as pulp canals or your root canals. So these are the root canal spaces. So this is the surrounding dentine. Then this radiolucent line. So this is your PDL and then your lamina dura. And this is your palatal cortex. This is your buccal cortex, right? Similarly here, we can see that white radio opaque part. This is nothing but the corticular bone. And the inside part, these are the trabeculae and these are the narrow spaces. Okay. So this is how normally the teeth and the surrounding structures will look like. So whenever there is air or whenever there is cavity, then it will appear as black, complete black. Soft tissue will appear as gray, and each structures will appear like how they appear in your IOPA. Now we will see some landmarks so that we can know where we are and which are helpful in implant planning procedures also. So what are the important landmarks in maxilla? In anterior region, your major landmark is your nasal cavity, right? It is apical to your incisors. So there is your nasal cavity, right? So this is the cross section, buccolingual section. So this is the nasal floor, and this upper black part, right, is your nasal cavity. This is your oral cavity. This is tongue. And this is the lip, labial mucosa appearing gray. Right. So we are clear with the anatomy. This is the bone, palatal cortex, labial cortex, and the marrow spaces with trabeculum. This is the tooth. The second landmark in the anterior region is your nasopalatal canal or the incisive foramen. So this nasopalatal canal will open as incisive foramen. So it is palatal to your central incisors 1, 1 and 2, 1. So it is important you avoid perforating them while placing implants in your anterior region. In the posterior region, the major landmark is your maxillary sinus, right? So like I said, the black cavity is your maxillary sinus. This is gray part, so it is soft tissue. So this is lining of the maxillary sinus. It is slightly thickened. Now white part, it is the cortical bone. So this is the floor of the maxillary sinus. Below are your bone marrow, and then this is the your alveolar cortex, as in crestal bone. Similar thing in a cross section view, buccolingual. So this is the floor of the maxillary sinus. These are the roots of the molar, and see the sinus is dipping in between the roots. It is seen many times. It dips between the two roots or between two teeth, right? So in maxillary sinus, we can see many things. Like in this view, if you see, this is the lateral medial part, this is the lateral part, this is the medial part. If you see this, this is your maxillary sinus, this is your nasal cavity. So we can check what for is the patency of this ostium. Ostium is where the sinus opens into the nasal cavity. It is in the middle meatus and it is non-dependent drainage. So while now in this case you need to do a sinus lift. So you have to see that the ostium is patent. It should be open. Second, what you can check is for the thickness of the lateral wall. When you go for a direct sinus lift, you'll have to make a window over there. So we have to check for the presence. We can check for the thickness and how much you have to drill. Right? And one more thing is the presence of. Yes.
Vinayak sir, sorry to disturb you. Now, since we are going continuously, there was one question to please repeat the position of nasopalatine canal with respect to maxillary incisors.
Okay.
Because क्या ऐसा repeat था इसके लिए मैं बोला बीच में अभी बता दो.
No problem, sir. No problem.
Yeah.
Now, if you see here, see these are the maxillary incisors, central incisors, and it is at the center. So it is palatal to the central incisors. If you see this axial section, this is the labial part and this is the palatal part. So this is your central incisor, lateral incisor, canine, first premolar, central incisor, lateral incisor, canine, first premolar. And this opening, can you see this? This is your nasopalatine canal where the incisive foramen opens at the apical part. So it is always palatal and at the center. It is palatal to 1121 and it is at the center. It is many times enlarged. So it goes till the distal of 11 and 21. And in case of if there is any cyst or something in that nasopalatine canal, then it can go up to lateral incisors also. Sir, okay?
Yeah.
So then, yeah, here we can check for the thickness of this lateral wall and also for the presence of PSA, so that we plan our incision so that we avoid damaging this posterior superior alveolar artery. So if you see here, there are variations in the position of this artery. Now here it is inside the sinus or the wall of the sinus. So it is intrasinus. Here is in the bone. So it is intraosseous. And here it is external to the bone. So it is superficial. Right. So we can see. So if you want to lift, plan for a lift or so the window. So we can make a window here. We can measure the distance, how far it is, and then we can plan. Another important thing is the presence of septa. Septa is something which is a bony protuberance which divides the sinus into two parts. So again, it is significant during sinus lift. So you cannot raise the sinus line. It will get torn if you raise it from there. So that you do it anterior to it or posterior to it, or you can go for a lateral approach. Another landmark is your zygoma. In case of severe alveolar resorption, we do zygomatic implants, right? So this part is the zygoma. Zygomatic arch is something which is behind, and this front part here, this is the zygoma proper bone, which is formed by the maxillary process, frontal process, palatine process. So all they fuse and they form this zygoma bone. So this is one landmark, and another landmark are your pterygoid plates, right? So there are two pterygoid plates, medial pterygoid plates and lateral pterygoid plates, and they are posterior to your third molar. So they are important when you do pterygoid implants, where you come from buccal and engage the either the medial pterygoid plate or in between the two plates. Now in mandible, the major landmarks are first is the genial tubercle and the lingual foramen. These are important because you get to know where your exact center is, right? So in mandibular, when you're planning for your overdenture or for implant, so you know where your midline is, and from there you can plan 5 mm distal or 10 mm distal. And most significant thing about this lingual foramen, this lingual foramen is always present at the center. It has variations. It may have one exit, it can have two exits, it can have three exits, right? But it is always at the center. And it is very important we avoid impinging on it. Why? Because it opens into the your sublingual space. So if we impinge on it, and if there is bleeding, because from this the lingual vessels come out, if there is bleeding, then it leads to a life-threatening condition. The sublingual hematoma is formed, the tongue is raised, and it is an emergency, and you will have to stop it from your carotid. You cannot directly compress it because it is opening into the outside the bone, right? So it cannot be compressed or stopped. So it is very important. That's why people now don't place implants at the center. Earlier they used to place. Now we place away from the center. Another thing is your labial fossa, right? So this labial fossa, we should see if it is present or not, because it will change the angulation of your implants, as well as if you want to go straight, then there are chances that there might be exposure. So you will have to plan it so that you can graft it or. Now in the premolar region, the main landmark is your mental foramen. So it is present between 4, 5, and 6 region, first premolar, second premolar, molar, and it is always buccally placed. So there is something called as anterior loop of the inferior alveolar nerve. In that, the nerve comes ahead and then opens into the and comes behind and opens. So if you see here, this is a mental foramen, but your nerve has come ahead and then gone behind. So that is your anterior loop of the nerve. So if you see here, your foramen is opening here in this slice, right? But your nerve is extending anterior to it. See, right? So this is the anterior loop. So we have to important to avoid it, to avoid paresthesia. And in the posterior region, the major landmarks are your mandibular canal, that is your inferior alveolar canal, and the submandibular salivary gland fossa. It is more prominent in the 7 region. Okay. So these are the major landmarks. So we know how a normal scan looks, where to look, and what is the principle. So now we can see the applications of the CBCT in dentistry.
Sir, there was one repeat for pterygoid plate, sir.
Okay. So this is the maxillary posterior region, the third molar. Then you have your maxillary tuberosity, right? And then is the pterygoid hamulus. And behind the pterygoid hamulus are your pterygoid plates. So these are the two. Now this is the axial section. So these are the two pterygoid plates, medial pterygoid plate and lateral pterygoid plate. Similarly, in this coronal section, we can see this medial pterygoid plate, and this is the lateral pterygoid plate. So These are important while placing pterygoid implants to know the anatomy and how to engage. So generally in pterygoid implants, what they do is they go from 7 region, 1-7 or 2-7 region from buccal surface and go palatal, distal and apical this way. So while doing that, you have to engage, come here and engage the medial pterygoid plate, right? So this is what these are the two pterygoid plates, lateral pterygoid plate and medial pterygoid plates, which is distal to the third molar after your pterygoid hamulus. Okay, sir? Sir?
Sir,
Hello.
if they have any more pictures, please show the pterygoid plates also.
These are the pterygoid plates, the arrow now which is showing. So this is the lateral pterygoid plate. This is the medial pterygoid plate. And even in this axial section, this arrow is showing this is the lateral pterygoid plate. This is the medial pterygoid plate. And these, so this is from the sagittal section here. So these are posterior to the maxilla, where your maxilla ends, right? So this is the maxillary. This is line, first premolar, second premolar, first molar, second molar, and this is the third molar. So after the third molar, there is your maxillary tuberosity ends, right? When we do our dentures, also we palpate where the PPS area. So it is where it ends, and posterior to it is your pterygoid hamulus. So this pterygoid hamulus is the pterygoid bone from which has its plates as well as the hamulus. So these are the two plates, medial plate and the lateral plate. So this is the medial plate, this is the lateral plate. Fine, sir?
सर एक अंकल एक मिनट अंकल एक मिनट सर विनायक सर कंटिन्यू कीजिए अभी
हाँ
कंटिन्यू कीजिए बाकी के क्वेश्चंस हम लोग रेगुलर लेते रहेंगे ये क्या कंटिन्यूटी में था इसके लिए मैंने
नहीं
आपसे
सर,
बीच में
वो
पूछा
कंटिन्यूटी में पूछिए चलेगा, कोई प्रॉब्लम नहीं है।
फिर
तो
आपका एक ही पॉइंट पे अटक जाएंगे सब लोग इसके लिए या हेलो
हाँ
हाँ
So now we will see applications in dentistry. So it is applicable in all fields of dentistry, and all the fields are interlinked. And I have covered, there are many topics which could be covered. I've covered few considering the time. So we'll see few of them. Now major depending on the indications I have put. So major indication for which we get scans is the implant site assessment. So here we can measure the height and width of the implant site, right? We can determine the subjective bone quality. There is no accurate bone density measurement. We can determine the long axis of the bone, see for the internal anatomies, any pathologies, and what are the jaw boundaries, right? So we can measure the height. Now height is measured from the crest of the ridge or subcrestal, right? If it is not flat, then we have to go subcrestal till the nearest anatomic landmark. So in the maxillary anterior region, the landmark, either it is the nasal floor or your nasopalatal canal. Maxillary posterior region till the floor of the sinus. In the mandibular anterior region to the inferior border of the mandible. In the premolar region till the mental foramen, and in the molar region we have measured from the crest till the inferior alveolar nerve. The measurements can be done till the landmarks, and the implants then can be placed 2 mm short of it as a safety measure, especially the nerve structures. These cortical structures can be approached to get your cortical anchorage, but then the nerves, it should be 2 mm short. Similarly, we can measure the width, right? Like here, you can measure the width. In few cases, the width is less at the crest, but as you go apical, the width increases. Then we can measure how much amount of bone we can reduce, and we get the desired width. So that much amount of alveolotomy or bone reduction we can do while doing the surgery, but we have to manage the soft tissues also along with it. Then presence of undercut. Now if you see this, it shows that there is lot of bone, right? but this undercut of the submandibular salivary gland fossa is not seen here. So this has tremendously reduced your available alveolar height. If you plan your processes somewhere here in this axis, then your height is not 15, it is 10. Right? So what you can do is either you go straight and place till 10, or you incline it and place a longer implant and give a tilted or angulated abutment. We can measure the angle of implant placement which we want to do, but it is very difficult to transfer it. If we want to accurately transfer it, then what we'll need is a surgical guide or a surgical stent. Then we can see for the presence of pathologies, like if in this case there is a root piece, in this case the buccal cortex or the labial cortex is only absent. So this is the bone which is present, labial cortex is absent, this is the nasopalatal canal, this is the labial mucosa and nasal cavity. And in this case, there is infection at periapical radiolucency with the extraction socket. So all these pathologies can be studied. And also what we can make out is a subjective bone density. You'll never get an accurate bone density, but seeing the amount of trabeculae and how dense they are, we can guess whether the bone is hard bone or a soft bone. So in case of soft bone, it would be more radiolucent, the marrow spaces would be large and trabeculae would be very thin, right? But in case of harder bone, the marrow spaces would be small, trabeculae would be wider, and it would be a thick bone. Also, along with it, we can place a virtual implant and see whether how it is and what are its relation with the surrounding structures. Next, more common most indication after your implant is the endodontics, right? So what we can see is we can check for the morphology of the roots, or the how the roots are, how the number of roots, the curvature of the roots. So if you can see this is the first molar and these are the two premolars. So here you will see the premolars, they have two roots on the buccal surface, right? And these are also curved like a horn of a cow. This premolar, this is the maxillary premolar having two buccal roots. Also, if you can see this mandibular premolar, it is having two roots. Yeah, this is the first premolar, second premolar, first molar is missing. So you can see how it is. There are two roots in this and two canals. These are also curved. Also, in this case, if you see the curvature of the premolar, even here. So this morphology and the curvatures in different planes, it can be seen in a CBCT scan. Like if you see this 6, it is showing taurodontism. The crown is enlarged at the expense of the roots, and the roots are also curved. They are not curved in one plane, but in all planes. If you see this is curved this way, this way, this way, this way, right? So all this anatomy, exact anatomy of the roots as well as the root canal system, it can be seen. Also, we can check for a number of extra canals, right? We have seen the anatomy. So these are the root canals. So if you see this is a canine. This is central lateral canine, central lateral canine. All these things, they are showing you two dots, right? So there are two root canals in this 4-1, 4-2, 4-3, 3-1, 3-2, 3-3, right? Many a times there is an accessory canal, but it is not seen on CBCT scan. This is because the voxel or the resolution of the CBCT scan goes up to 60 or 60, 70, 80, not less than 60 microns. And 60 microns is a 6 number file, right? So sometimes the canals are so small that and calcified that they are not negotiated by 6 number also. So there, in such cases, if the resolution of the canal is less than the resolution of the CBCT scan, then it won't be seen on the CBCT scan. The best thing to see or find an extra canal is would be a microscope. When you do the microscopic dentistry, it is the most accurate thing to see for an extra canal. But yes, in the axial sections, we can see for the number of canals. Now, if you see this first premolar here, it is also having two buccal root canals, right? And one palatal. See this 1 and 2. This is the maxillary molar. It is having two canals in mesobuccal root, MB1 and MB2. So this MB1 is not filled, and there is this periapical radiolucency, perforation of the lateral wall of sinus. You can see this, right? There is periapical radiolucency and haziness in the sinus. All mucus proliferation in the sinus, because otherwise the sinus would appear dark black, right? Because it's a cavity. Now the soft tissue has proliferated, that is the flow lining of the sinus has proliferated. Also, what we can check is the extent of the periapical infection. Like if there is a radicular cyst, then what is the extent? How much teeth is it involving? Is there any resorption? Is there any expansion, etc.? So all these things can be seen. Right? Now, if you see here, there is cyst, radicular cyst associated with 1, 2. So now if you see here, this is your 1, 2, right? This is your 1, 1. This is 2, 1, 1, 3, 1, 4. So you can see this radiolucency, right? So this is the cystic cavity. Now there is expansion of this buccal labial cortex, right? Thinning of this palatal as well as labial cortex. So all these things can be seen. So we can see if there is perforation, if there is expansion, if there is root resorption, and how much teeth is it involving. So this now periapical is involving the palatal root of the first premolar also. So we'll have to check the vitality of that tooth before doing a root canal of it or not. Similarly in 1/6, right? See this big radiolucency and with the lifting of the floor of the sinus. Right? This is nothing but a radicular cyst associated with 1/6. You can see the floor of the sinus is raised. Now, if you see the shape, it is raised towards the floor of the sinus, right? It is this way. So that means the pathology is of odontogenic origin and it has lifted the floor above. If the pathology is of maxillary sinus origin, then this floor of the sinus would be this way, downward scalloping. Right? So this is how you'll distinguish if the pathology is originated, if it is involving both the thing, then it is how you distinguish whether it is from the sinus or it is from the teeth. Next is presence or absence of fracture. Again, to check for a fracture line, there has to be separation between the two fractured segments. If the separation is less, or if there is no separation, or it is less than the resolution of a CBCT scan, it won't be, the fracture line won't be clearly seen. But what you can see is the secondary signs. If it's a chronic fracture case, then you will see secondary signs such as there would be radiolucency in the furcation, right? There would be a complete bone defect, like you see here. The bone defect will go from the crest till the apex of the root. So these are the indirect signs. A J-shaped bone defect. While probing, you'll suddenly get a dip and you'll get a sinus. All these are signs of fracture. Now this is a through and through fracture in man. So these are displaced fractures, so they could be easily seen. Another method to confirm displaced fracture is you can ask the patient to bite on a cotton roll and then take a scan. So when patient bites on it, the segments, they will move a little bit apart and you can then check for the presence or absence of fracture. Now here there is horizontal fracture. Next is resorption. Resorption could be internal or external. So how you will see is it will be seen as a discontinuity in the dentine, right? If you see the dentine here, it is continuous in this central, on the mesial surface of this lateral, but on the distal surface, if you see, the dentine is discontinuous and this GP point is open, exposed to the external environment. This is nothing but external resorption. And because of that, there is this big periapical radicular cyst. You see here also in this case, there are multiple radiolucencies, right? We break in the discontinuity of the dentine. Nothing but resorption with periapical radiolucency. Also, what you can check is you can check for the whether the obturation done is complete or not, whether it is overextended, whether it is underextended. All these things can be seen. So in this case, if it is short of apex, Right? We can measure on the software how much short it is. Here it is extending beyond the apex. Now, if you want to check for a fracture line, it is very difficult to check in present of this GP point or a radiopaque object because of the metal artifact which is normally seen. So it is very difficult to come in. So if you want to check, it is either you remove the GP point and then do the scan. We can check for the location of the broken instrument. So we can clinically also check the canal which is shorter in length if it is broken. But if you want to retrieve it and if you want to see exactly where it is and how to bypass it or how to retrieve it, then a CBCT scan would be helpful in finding the location of that your separated instrument. And you can also determine the working length, but it is very subjective because it is very difficult you go in the same angle as which you are measuring it, or and your reference point may also vary. So your working length may also vary. So the best method to determine the working length would be your radiographs, or as in by the diagnostic working length radiograph, or your apex locator. Next, in phase of oral surgeries, the most common indication is to assess the relation of third molar to the nerve, which we had already seen. Still, we'll see one case. Now, where you see the nerve is in close proximity to this third molar, 4/8. Now, on this cross section, we can see it is passing between the two roots, right? It is buccal to this lingual root, and it is at contact with the crest. Also, we can see the curvature of the roots. Now, this curvature will never seen here. You can never appreciate because it is curved in the buccal direction. This is not seen. Right? So this can be seen and we can prepare or we can plan our extraction accordingly. Next is presence or absence of impacted teeth. Right? Presence of impacted teeth, if you want to know the location of that impacted teeth and whether it is in contact with the teeth or with the vital structures, then that also can be seen. And this is an impacted 4-5. So we can make out that the crown, right? It is lingually placed and near the alveolar crest, and the root is labially placed, and it is near your mental foramen. It is in close proximity. So while extracting or while removing the tooth, we will be cautious. Also, we can assess for the extent of the trauma to check the fractures, which teeth are involved, how many plates are involved, how the fracture is, whether it is continuous, whether it is comminuted. Now, if you see this, there are so many fragments. So you can have a better study of the fracture. Like this is involving the central incisor. So you can see coronal fracture over here. You can see this radiolucent line here as well as here. So there is fracture of the 1-1, 2-1. Also in 2-2 region, we can see there is discontinuity of the labial cortex, right, at the apex of the socket of 2-2. 2-2 is avulsed along with dentoalveolar fracture of the bone. So in this case, there is right parasymphysis fracture. So we can see how that involving both the plates, the buccal as well as lingual cortex, it is displaced, right? Whether the tooth is involved in the fracture line, whether the nerve canal is involved. Since this is anterior to the foramen, the inferior alveolar nerve is not involved, and no tooth structure was involved in the line. But still, this 4 has been exposed. This is the fracture of the TMJ, subcondylar fracture, in which the condyle is displaced, right? Also, we can check for the extent of the tumors. Now, if you see here, there is this good radiolucency, well-defined radiolucency between 3-3 and 3-4. Corticated borders and internal structure is radiolucent. But if we see it in a 3D view, there is more to it, right? It is, there are septae. Can you see this septa appearing? So giving it a multilocular appearance, right? There is displacement of this canine, and then it came out to be an ameloblastoma. You can see here it is expansion of the buccal plate, thinning of the buccal plate, resorption of the premolar. So it was a case of ameloblastoma. One more case now in the posterior ramus region and the body region. Now we have constructed slices. We go posterior from the premolar region. So this is the premolar, this is the first molar region, second molar region, third molar region, and the ramus region. So this is the premolar nothing. But in the first molar, you can see there is this pathology which has started. Right? There is discontinuity of the buccal cortex, and there is this expansion also. So this is the lesion starting from the first molar, extending behind. This is the second molar. You can see multilocular appearance over here. And there is thinning of the lingual cortex as well as expansion, thinning and expansion of both buccal and lingual cortex. Now, if it is a cyst, dentigerous cyst or then in dentigerous cyst, there is expansion of only a single cortex, either buccal or lingual. Ideally, but in a tumor or in ameloblastoma, both the buccal as well as lingual cortices, they are expanded. Right? So here we can see the expansion and it has hollowed the entire ramus. Nothing is remaining in the ramus. Right? And the axial sections showing the lesion. So nothing but an ameloblastoma. Now here you can see there is an impacted mesodens, right? Similar thing, we can check there is expansion of the labial cortex, there is pericoronal radiolucency, right, around this tooth. We can check the position of the tooth like this, the root is palatally placed. It is extending till the floor of the sinus. Right, see here expansion, amount of labial expansion. This white line is the cortex. And there is perforation also of this cortex here. There's nothing but this is a dentigerous cyst with an impacted mesodens. See this expansion. Same thing in cross sections. You can see the expansion. And this is the position of the tooth. The root apex is palatally placed. It is apical to 1-1 and 2-1. Now, if you see this OPG, see this premolar, it is upright, and there is this radiolucency here. These premolars are erupted properly, is in the eruption stage, but they are in the normal position. But this is quite apical to it. So, in a CBCT scan, we found again pericoronal radiolucency attached to the neck of the tooth, right? So the tooth is displaced now towards the roof of the maxillary sinus. The floor of the maxillary sinus is also lifted, and you see that the sinus space, see the black thing is the sinus, right? So it is shrunken, right? It is reduced due to this dentigerous cyst. So we come to know the extent, whether it is involved in the sinus cavity or not, whether it is involving the other spaces or not. That can be easily studied. If you see this case, there is this radiopacity, right? So it could be a lymph node or a cyanolymph. Now, because patient had an history of swelling while eating, difficulty in salivation, so the diagnosis was a cyanolymph. So you can see, you can measure, see it, it is lingual to the ramus. Now this is the ramus region, right? So it is lingually placed in the submandibular region. So it is cyanolymph of submandibular salivary gland. This is the axial section, right? So this is the teeth region and this is the ramus region. So it is lingually placed. See here. This is where more teeth will end, but it is. This is one case of fibrous dysplasia. So the patient had swelling in the maxilla, only one side, one swelling, and you can see very homogeneous bone, right? And ground glass appearance, uniform marrow, etc. Right? So it is typical of fibrous dysplasia, plateau shape expansion, young female patient with swelling in the single bone. The axial sections. It is merging with the normal bone. No discrete borders. Here you can see. Next we will see osteomyelitis. Okay. So osteomyelitis will also occur as a mixed radiopaque radiolucent lesion. So now there is extraction pocket of this premolar molar tooth, and from this the periapical infection has spread. See this radiolucency, and this is spreading downwards here, and now this has spread in the entire ramus and the posterior body. Now if you see the cortex, normally it is white, right? It's bright white. Now if you see dots in this cortex, right? So this is typical of osteomyelitis, where you see radiolucencies in the cortex and giving it a moth-eaten appearance, which is characteristic of chronic osteomyelitis. Like how a moth eats a leaf, right? This is a similar appearance, which is seen. You can see it in the sagittal sections as well as the axial sections. So mixed opaque radiolucent lesion with sequestrum in between. History of extraction, chronic inflammation. Clinically also patient will have swelling, pus discharge. Next we will see oroenteral communication. Right? Now when we had seen the normal landmarks, we had seen that sinus is the black cavity. Then there is the lining of the sinus. Then there is this cortical floor of the sinus. Right? If you see here, this cortical floor is not continuous. Right? There is discontinuity in the cortical floor of the maxillary sinus. This is nothing but an oroentral fistula or oroentral communication. Now, in this case, the body has responded by proliferation of the lining mucosa. So, the body has tried to cover the perforation on its own. This occurs. Sometimes the body doesn't form, so there would be a through and through perforation through the soft tissue also. So, this is only through the bone, but the soft tissue has grown in between. Also, you can assess for the patency of the airway. Now, if you see this radio, like I said, airway or airspace will appear black or radiolucent. So this is a nasal cavity, right? This is the oral cavity, and this is your pharynx. And what is seen here are your tonsils, your pharyngeal tonsils or the adenoids. So now, because these tonsils they are enlarged, your pharyngeal airway is compressed or it has shrink. So generally the airway would be this way. So because of the enlargement of the tonsil, the airway has shrunk. So it is seen even in cases of sleep apnea, because of this enlarged tonsils, the airway is shrunk and there is difficulty in breathing. So we can do this airway assessment also. Also TMJ, we had seen in other things also, the fracture and everything. So this is the case in which there is a chondroma of the condyle. So the condyle has grown in size. See. Axillary sinus again, we had seen all this, the ostium, the lateral wall, presence of septa, and mucosal thickening. The mucosal thickening can be graded into 4 types. One is only mucosal thickening, that is small thickening of the lining mucosa. Second is a polypoid mass. So mass would be in the shape of a polyp, right? So it is sometimes called as benign mucosal cyst of the maxillary sinus. So it is a polypoid mass which is filled with mucus. There could be an air fluid level. In case of sinusitis, there could be pus formation, there would be mucus secretion. So because of that, there is air fluid level. So this part is the air. This is the mucosa fluid and everything. So this is the air fluid level. It will show air bubbles in between. So there would be radiolucent, round radiolucence is in between. And fourth thing is your complete opacification of your maxillary sinus. The entire sinus space is opacified.
Sir, just a minute, sir. Sir, just a
Yes.
minute.
Huh.
Just a minute, please, 1 minute. Friends, please mute your audios because there is disturbance during the presentation. Request you all to please mute the audios. Please. Sir.
Hmm. Next, in orthodontics, all the majority of the purposes of the orthodontics have been covered in the previous slides. Still, I will show some. So for the impacted location of the impacted tooth, so we can determine whether to keep that tooth or get it in the arch, or we have to extract that tooth. That can be done. Second is, in this case, this is ortho treatment. Now the tooth has been so labally taken that now there is no labial cortex, right? The bundle bone and the is fused. If you take more out, then there would be fenestration. So then we have to determine whether to what treatment we have to see. So to plan that treatment, it would be important. Also using various orthodontic software, we can do the analysis on the software. So there is no need to do the tracing and do the analysis, SLA, SB, or your downs analysis and everything. It can be done on the software. There are softwares like Dolphin, etc., where it can be done. In perio, we can check for the amount of bone loss, but not on the 3D view, but on the 2D images like here, right? So we can see what is the nature of the bone loss, whether it is horizontal, whether it is vertical, whether it is the crescent shape. It can be done, right? Pocket cannot be measured, but we have the soft tissue thickness. So this soft tissue where it is and the amount of bone loss that we can measure, right? We can measure the amount of soft tissue which is there. And second most important thing is that in the cross section, we can see the buccal cortex and the lingual cortex separately. Now in an IOP and OPG, we will never get to see the two cortices or the buccal cortex or the lingual cortex separately. So in this case, we can see the labial cortex is here and the lingual cortex is here. So there is this much of bone loss in the labial surface. Also, if you see this is nothing but calculus formation. So here the calculus is subgingival and the what we say the bone loss is 2 to 3 mm apical to it. Similarly here, so that is the biological width it has to maintain. Also, you can check for the bone loss in the furcation region. No, these are the advantages of the CBCT scan. Now, what are the disadvantages of the CBCT scan? The first major disadvantage is poor soft tissue contrast. CBCT is good to study hard tissue structures. Whenever you want to study bone, then a CBCT machine, a CBCT scan is useful. Whenever you want to see teeth, a CBCT scan is useful. But when the lesion is involving the soft tissue, like your gingiva, like your lip, like tongue, buccal mucosa, then the CBCT is of limited use. It won't give you any soft tissue contrast or soft tissue detail. So in such cases, if it is superficial, either you go for an USG or you go for an MRI or a CT scan in soft tissue mode. If you want to check for malignancy, right? Always a CT scan is better for malignancy because CBCT will never give you the soft tissue extent of the lesion. And oral squamous cell carcinoma, they generally are most commonly they begin in the soft tissue and then they incorporate the bone. Yes, there are intraosseous also, but generally it is first soft tissue. So in case of if you are suspecting anything in the lip, anything in the tongue, like a lymphangioma, hemangioma, or any tumor, or any lesion which has a soft tissue extent, then you don't go for a CBCT scan, you go for a CT scan. Image noise is like for in all the radiographs, it's a similar thing. Now, because in an IOPA or an OPG, the field is less, so the noise is less. But in a CBCT, the area exposed is more, so there is more of a more of a what you say, scatter and more of noise. And third and most important thing is your artifacts. Whenever there is metal present, there is artifact seen, whether it be CBCT, whether it is CT. In CT, the artifact is more, and in CBCT, the artifact is less. But whenever there is metal next to it, you will see a radiolucent line or radiolucent thing, uh, which is called as a introduced type of artifact or beam hardening, it is called. So there are various things seen in it. So what happens is the diagnostic property is lost next to this metallic region. So if you have a fixed bridge which is having metallic component or porcelain component, then that bridge, adjacent to that bridge, there would be distortion. The diagnostic value would be affected. So either you have to remove the bridge and take the scan, or uh, there would be artifacts. Even when you place an immediate implant and it is slightly labelly placed, and if you take a scan immediately, you will see that there is no label bone, but that is nothing but an artifact. And the confirmation is because you have placed it immediately and there was bone at that time. The clinical finding is a confirmatory, not the uh, CBCT finding. Because if it is too labelly placed and it is very next to the cortex, then at times the cortex might not be seen. So this is another disadvantage of a CBCT scan. So whenever there is metal, like I said in and when during endo time also, if there is GP point present, so the radio presence seen. If you want to check fracture next to it, then you'll have to depend upon the secondary signs, which is a periapical infection, bone loss, complete bone loss, J-shape defect, etc. Now, what are the advantages of the CBCT scan to the referring dentist? Is first is we can visualize the anatomy that which we cannot normally see, and we can see where the critical structures are, and depending upon that, we can assess what is the risk, amount of risk in a particular procedure, and we can plan a procedure and select what procedure which we want to do. Scope of improvement will definitely be soft tissue enhancement, contrast. Second is derivation of Hounsfield units and other softwares. There are now the softwares are developed, but more user friendly softwares. Now, many a times we just prescribe a scan. I mean, there is nothing written on the paper ki what is the purpose. So the radiologist also doesn't know what to report or what to do, and the somewhere the purpose is lost in between. So in that case, the solution is there should be a good communication between you and your radiologist. So there are some things if which you mention on the your prescription paper or write it, then it will become easier for your radio or you to understand what you want and give the report according to your need. So if you can specify what you want, then a customized report can be made. Like if you can mention the purpose of the scan, whether you want to do it for implant planning or for impacted tooth, etc. Then if you mention it, or if you're suspecting any pathology in case of an extraction site, because if there is an extraction site, because majority of the cases of implants only, we feel ki no, it is for implant placement, but at times it is patient might be having pain in that extraction site. So we just need to mention what is the purpose. Second is if it is for the implant planning, then we can specify the region where you are planning, especially if it's a big completely edentulous thing. So if there is something in the mind, then that can be conveyed and the plan can be or the measurements can be done accordingly. And whenever a report is made, there are hard copies. So in hard copies, there are few sections, right? There is an axial section, there is an OPG section, and then there are cross sections. So this distance between the cross sections, we can ask our radiologist what distance we want. Whether we want it at 1 mm, whether we want it as 2 mm. For implant, it is okay 1 mm or 2 mm. But if you want to do it for an endo purpose, then you might need it at 0.5, 0.4, 0.3. So that you can ask. And now then also many a times we are well versed with the software, so we don't need reporting. So we can just mention key, we don't need any type of reporting, or we need only images and we will do our own measurements, or we need only DICOM images that we can open it in some other software. DICOM is a method in which the CBCT data is exported. Like our image is exported in JPG or PNG form. Similarly, the CT scan, the CBCT scan, it is exported in DICOM format. So these DICOM images, they can be then opened in a third-party software or in any other software. So there are many free softwares like Blue Sky Bio, where you can import this DICOM data and you can do your own planning. At times you will need only nerve marking and then you will do the measurement. So you just convey it, and that would be helpful in getting a good report. Okay, so I'd like to conclude. This Shashi Kapoor and Zinat Aman from the movie Satyam Shivam Sundaram. Right? He sees her, he falls in love with her, and they decide to marry. And during their marriage, he sees that there is some scar in it, and he runs away. But then afterwards, he realizes that scar is not a problem. It is okay, right? But he ran away. Then he came back and he accepted her. But the reason he ran away was because it came to him as a shock, right? Now, this is not bad. It just came as a shock to him. That's why he ran away. Similarly, these things, they are not bad, right? And if we don't do a CBCT scan and you plan your implant surgery, you open the flap and you see there is no labial cortex, then you are not prepared because you have not seen the scan and you don't know the structure. Then you will run away. Or if you see this and you see 1 mm width bone, you're not prepared because not seen a scan, you will run away. You see an extraction socket which is wide, you run away, right? So, but if you had taken a scan pre-hand and you had known this condition, then you would be ready with the graft or your expansion kit. You will know that there is an undercut over there inferiorly, so you will have to angulate it or you will have to reduce, decrease your working length. You will come to know that there is a root piece over there. So before drilling, either I have to extract it or while drilling, I have to take care that I take it out. Or in this case, you will know that there is an extra canal. So while doing your access cavity preparation or BMP, you know that there is an extra canal, right? So a pre-CBCT scan would always be helpful in diagnosing and planning your treatment, right? Thank you.
Yeah, thank you, Dr. Vinayak.
Welcome,
It
sir.
was really great. I would like Dr. Jashan to please come online, unmute
Yes, sir,
himself.
I'm online.
Yeah, okay. So there are a few questions. There are plenty of list of questions, I suppose, today because they are really interested in knowing these things, I suppose, today.
Yes, sir.
So what are the basic requirements right from starting? So I'm taking the questions from starting only. What are the basic requirements of a laptop for a CBCT?
Laptop, as in for your personal use, Windows 7 and above is okay. Apple is anytime better, but generally all the softwares, they don't open on Apple. So majority of the softwares, they open on Windows only. So Windows 7, you should have a good RAM. Minimum 4 GB RAM should be there. A good NVIDIA graphic card, which should be a dedicated graphic card for an ideal computer in which you can work faster, and good RAM. That is essential. Even if it is less, it will work, but it would be slow. So minimum of 4 GB RAM, a good NVIDIA dedicated graphic card. There are two types of graphic cards. Normal graphic cards are there, but it gets divided into other programs. So a dedicated graphic cards doesn't go in your Windows program. It will be only for your gaming programs or your softwares. So that is needed, a good dedicated graphic card, high RAM, 8 GB, 16 GB is excellent, but minimum 4 GB RAM, and as advanced an operating system. So Windows 7 is okay. XP and others, they are off, as in, then it would be very slow. The scan would take 2-3 years, as in not years, 2-3 months to open.
Okay. So Dr. Deepa asks, can I read a CBCT scan on my laptop even if I don't have a CBCT software installed in my
No, you will need a CBCT software installed. Or there are free softwares. Like I said, there is this Blue Sky Bio. which is available freely on Google. As in, we can download that software. It is free to plan. So what you can do is you can ask your radiology center to send you DICOM files. So these DICOM files, then you can import in this Blue Sky Bio software, and then there are many online YouTube videos of how to use that software. So you can study the software on that and open it. But the software is necessary, otherwise it won't open. Like even if you want to open a video, you need a VLC player or some player. It won't open on its own.
Okay. So how accurate is a stitched image?
Stitched image, there are chances it could be inaccurate, because if we are dependent on the machine to get it stitched, so there are chances that there would be 100 to 200 microns discrepancy, because the discrepancy would be there at the edge where the images are stitched. So there are chances that there would be discrepancy in the stitched image. It is always better you use a machine which doesn't allow stitching, or the images they cover the full FOV which is needed.
Okay. So can the length of the loop be measured accurately? Dr. Amruta Wadekar is asking, can the length of the loop be measured accurately?
Yes, we can measure it. Length of the loop can be measured, as in we have to trace the canal properly. Then in the sagittal sections, we can draw from where your opening is there and where your nerve is ending. That point you can measure with the measuring tool. It can be done.
Okay. So I think so. There is one question from Miss Dr. Kinneri Sangvi. She's asking why in central of the mandible implant can't be placed.
It can be placed, but it is very risky because the lingual foramen is there and it opens into your sublingual space. So by mistake, if you implant impinges on that on your lingual foramen, so it is the lingual foramen is a point of exit of your lingual vessels. Now, if there is bleeding inside the bone, you can compress it and that bleeding reduces. Now, because it is into the soft tissue or into the sublingual space, you cannot compress it and that bleeding won't stop there. You have to compress here, and you have to open and you have to compress the, your carotid artery. Otherwise, there will be big sublingual hematoma. Patient may die also because of difficulty in breathing.
Okay. So Dr. Milin wants to know, do you recommend using CBCT prior to all endo cases?
Prior to all endo cases, okay, yes, it would be great if, if you do it, but I know it is not feasible. If it is a full mouth case, then yes, we can go for a scan. And suppose we are doing 5-6 root canals, then it becomes feasible for this for us also, because it should be affordable to patient. Yes, but if it is possible, then definitely yes, because we get to know the anatomy of the canals.
Accessory canals. Yes, accessory canals can also be, the curvature will be known properly. Yeah, plenty of anatomy you get to know in that CBCT prior to endodontic root canal treatment.
Yes, anatomy and the number of canals.
Yeah. So which is the best view or a plane to study vertical root fracture in a tooth?
So there is not a single view in which we can study it in best. That is the advantage of a 3D thing. You will see it in all the views simultaneously. You will have to correlate it, and the fracture is not even though it's a straight line, it is not straight. It might be this straight, this straight. So you'll have to align it and you'll have to play with the software and see it all the views simultaneously. So you have to scroll in the sagittal view, axial view, and at the same time you have to see in all the views to see it. If you want now, what extent you want to see? If you want to see the mesodistal extent or buccolingual extent, then that you will see it on the axial view clearly. If you want to see the anterior-posterior also, then it will be seen on the sagittal view. If it is going anterior, it is going posterior. And in cross sections, again, buccal lingual can be seen clearly. So you have to be dependent on all the views and you have to see it in all the sections, as in all the views are necessary.
Okay. So congratulations to you. You have become an implantologist too, answering the questions on implants also. Dr. Ritesh is asking, in mucus proliferated cases, what precautions to take for planning of sinus lift procedures for implants?
Generally, what we can do is we can take an FNSC if there is mucosal polyp or mucosal thickening. Either FNSC can be done, and what is the content inside. If it is just a mucus exudate, then yes, you can lift the sinus and do it. But if it is not mucus or there is some other pathology, then yes, a ENT referral is necessary, and working with the ENT would be helpful.
Okay. So how could you differentiate between external and internal resorption? Please explain.
It is very difficult to differentiate between external and internal resorption. But in case of external resorption, the anatomy of the, what you say, your root canal or the nerve canal is maintained. The shape of the nerve canal, how the, what you say, the canal appears is maintained. But in case of internal resorption, the shape of the root canal is not the same properly.
Okay.
Because it is from the interior, the radiolucency will go from inside out. So the normal anatomy of the pulp or of your root canal in the tooth, it would be different. If it isn't from the external, there would be discontinuity of the as in the dentine there, but the internal shape of the root canal would be intact as it is.
Okay. So, Dr. Darshika wants to know, the prints, the hard copies provide only certain sections of the scan. The CD provided has all the sections. How to use the software to check all the sections?
Yes, for that you'll have to get yourself trained with the software. Whichever CBCT, what you say, center is nearby, they'll be giving it to in the CD. So you can either ask them to show a demo of their software, how it works. So once it show you how it works, and you can yourself do it. As in, we do that. Whenever any doctor needs anything, I personally go to the clinic and show them how the software works, and then you can use it on your own.
Okay. Dr. Milind Saudagar wants to know, are there any software which can remove artifacts?
Yes, as in there are various companies, as in machines which come with this thing. It is called as MARS, Metal Artifact Reduction System. So it is inbuilt in the machines, and then we can take the scan with MARS or without MARS. It is there in Sirona. I would like to thank Milind Saudagar sir, because I have learned CBCT at his clinic during my PG days. He has one who has taught me CBCT. So the
Jashan.
Yes, sir.
No. He's speaking. He's speaking. Yes, sir. Dr. Vinayak, sir,
companies will come with machines which are having, like Sirona has Mars, even Kodak has metal artifact reduction system, the cash stream, or what you say, Plan Mecha, it has. But the inexpensive machines, like where I won't take the name, in which the image qualities are also not good, they don't have these things. So this could be incorporated in the machine itself, metal artifact reduction.
Okay. So Dr. Shakti Kumar has a CS 3D viewer in the laptop. It came with the CBCT data, but I'm unable to view 3D views. Besides this, I have Nvidia GeForce 940 MC. Please guide, sir. Please repeat free online software name.
The name of the free online software is Blue Sky Bio. In that, you will definitely get to see the three-dimensional things. Now, this is not opening now. It is because of the type of installation. For that, the CS software is available in various modes. It is a center mode. They have imaging center mode. They have dentist mode and one more mode. I don't use CS software, as in I use, but that's not my regular software. So the CS guys would be much helpful in guiding you with the CS software. But you can definitely see the 3D views in Blue Sky Bio. It would 100% show you.
Yeah, Jashan.
Yes, sir.
Dr.
I have
Jashan.
one question with me
Yeah,
over here.
continue the questions. There are a few questions which can be seen, so you can please continue
Yes.
those. Yeah.
Dr. Jay is asking, sir, can we take a CBCT for diagnosing a cyalolith in the parotid duct?
Cyalolith in parotid duct, yes, we can take, but for that, there has to be, what you say, calcification should be there, as in more than the calcification should be more than for 30 to 40% for it to be seen. Sometimes what happens, because it is in the soft tissue, right? So CBCT won't give you soft tissue details. So you won't be able to see the duct, you won't be able to see the gland. But if there is calcification in it and it is more than 30 to 40%, then that calcification can be seen on the scan. Like where I had shown the case of submandibular gland. In that case, there was good calcification present, which was more as good as the next bone next to it, right? So that was the thing. So it can be seen, but providedly there is calcification in that thing, because there are radiolucent, what you say, calcifications also, in which the amount of calcification is less than 30%.
Yeah.
Yep, we have one more question saying Dr. Shabil Mustafa. He is asking DICOM images if they are compatible with third-party softwares and which is a good third-party software.
Currently, so Blue Sky Bio is there, which is freely available. Otherwise, you will have to buy softwares, and they are worth 4 to 5 lakhs. So there is 3D diagnosis, 3D, which I work with. There is 3Shape. There is what do you say, Anatomage. There are many softwares. What you say, in not recollecting the name, but there are many softwares, but they are paid. Free is only one, Blue Sky Bio.
Great, great, great. I think we have covered up all the questions. Have I missed any?
There are few. Even if I don't have a CB, they are started all. I think so. Let's go to end. Recommended.
Yes, sir, we have covered all.
Or na?
Yes, sir.
Great. Yeah. Sure. Yeah. Friends, still, if you don't have, if you feel that there are few more questions, even after the end of this webinar, Dr. Vinayak will be available till tonight on the webinar groups. He'll be clearing all your doubts till tonight, 9 o'clock. Tomorrow, we have a lecture on bone graft substitutes by Dr. Amit Gupta. What and where to use. Dr. Jason, please once again put up the slide, please.
Yes, sir. Chalu kar raha hoon.
Yeah. We had this series of webinar was started. He was the first lecturer to be a part of this series of 19 webinars. He had shown us the ways to sterilization and infection control in this COVID-19 era. And tomorrow he's going to speak on bone graft substitutes, where and what to use. Dr. Amit Gupta, oral and maxillofacial surgeon. So see you tomorrow once again at 3:30 p.m. on Zoom Cloud app and YouTube channel IDA MWSB. Request you all to please go on the YouTube channel, like, share, and subscribe to this channel, so that encourages us to make more and more videos and post more and more lectures for the betterment of our dental fraternity and our fellow dentists. Thank you, Dr. Justin. And thanks, Dr. Vinayak. Sorry, I think so. First, you will be eligible for a thanks because you are the integral part of this webinar series.
Yes,
Friends,
sir. Completely agreed.
Dr. Vinayak Shirsekar has sponsored the entire series of webinars to IDA MWSB, Mumbai West Suburban Branch. Thanks a lot, Dr. Vinayak.
Welcome, sir.
Thank you, Vinayak, sir, from the bottom of my heart for sponsoring the entire series of webinars. And thank you for giving us the time. I've been sitting for this lecture of CBCT of yours for the 6th time. And I'll tell you every time, there is something new to learn from the series of lectures that you have given.
Thank Thank you. Thank you.
So thank you, Vinayak, for coming every time whenever we ask you to be here. Thank you for giving your time, doctor. Thank
Welcome.
you.
Yeah.
We'll
Yeah,
be
Dr.
end,
Jashan.
yes, we'll be ending the meeting now. Seeing
Yeah,
you
Dr.
again
Jashan,
soon. Sir.
just call me up once it finishes. Oh?
Yes, sir.
Yeah.
Thank you.